serve Dr. Korosoglou during his presentation.
Great. So I guess I can begin, right? So I guess you all see my screen and you can hear me. I would like to, or I proposed with this forum for the ENSUPRO trial. The title is a comparison of an endovascular or surgical treatment options for patients that present with critical limb-threatening ischemia due to a prosthetic femoropopliteal bypass occlusion. So we all know in this round that coronary artery disease and peripheral artery disease are triggered by almost the same risk factors, including diabetes, hypertension, high cholesterol levels, smoking, and genetics. And we also know that the prevalence of peripheral artery disease has a significant healthcare burden nowadays, and this is actually going to rise even more because we have an increasing rise of aging patients and also of other comorbidities, for example, diabetes, which is a very important trigger in especially in patients with PAD and critical limb ischemia. So PAD is estimated to affect actually over 200 million of individuals worldwide in a couple of years. Of course, there is with PAD a very important cornerstone. We should not forget this is the optimal medical treatment. And of course, there are, I would not say competitive, but actually both complementary methods as interventional endovascular treatment of PAD and open surgery. With endovascular treatment, we have basic treatment options such as balloon angioplasty, bare metal stents, drug-eluting stents, and drug-coated balloons. And of course, for patients that have more calcium and more complex lesions, there is increasing need for atherectomy devices in order to tackle and improve the vessel compliance before treating such complex lesions. Of course, despite the development of endovascular therapy, there are lesions that cannot be treated endovascularly or that fail after repeated endovascular treatment. Actually, the current guidelines also, despite the technical developments, do rather go for an open surgical treatment in very, very long and very calcified femoropopliteal lesions. So we have also a relevant number of patients that undergo femoropopliteal bypass surgery. And of course, the question is what to do or what is the optimal treatment modality when such a prosthetic femoropopliteal bypass graft fails. And I think this is something that can happen. Actually, it happens quite frequently in our routine. And I think, therefore, it's sort of an unmet clinical need how to optimally treat such patients. There are several treatment options which can be performed in such patients. Also according to the clinical presentation and to the acuity of the bypass occlusion. Some of them are listed here. We can discuss that in the round probably, but I'm sure that local lysis is something that is being performed. Of course, with lysis, you have the bleeding complications. Some centers may perform a percutaneous approach, such as embolectomy for gutty embolectomy, or a percutaneous, fully percutaneous approach, such as rotarex thrombectomy. You can combine, of course, these treatment modalities also with additional PTA or additionally covered stents. And of course, you can do redo bypass surgery and patch angioplasty, or one could even let's say neglect the bypass and say we now go for the native artery, but this is also not so easy. after, for example, femoral and endarterectomy in the common femoral artery due to problems with the re-entry of such lesions. So the primary objective of the project I would like to propose, and I hope it's of interest to you, is what actually could be the optimal treatment strategy in such patients, of course, depending on the presentation of the patients, if it's chronic, subacute, or acute, the occlusion. In addition, outcomes need to be involved in such a study in terms of limb outcomes, and the change in the Rutherford category, a follow-up, and of course minor or major amputation. And this needs to be systematically analyzed in the patients included. We propose that as a multi-center, probably in the first line as a retrospective observational study. And the outcome measures we would like to include is re-interventions, restenosis, re-occlusion, the ankle brachial index, minor and major amputation, and if possible or if available, the grades of wound healing. We will need probably a waived informed consent because the patients have been treated clinically in the way they have been treated according to the standard operating procedures in the centers that have been dealing with such patients. And inclusion criteria is an acute or subacute occlusion of a prosthetic bypass graft. These are two cases I would like to share with you. So this is a patient actually that came to us about half a year ago, and about 10 months ago he had a prosthetic bypass graft, femoral popliteal. He had a subacute occlusion when he came, and a critical limb ischemia with rest pain. And as you can see here in the angiography, you can see a stump here in this region. You can see the profunda, the deep femoral artery, and a very slow flow in the periphery. And what we did in this patient is an undergrad wire passage and then Rotarex thrombectomy with 8 French. However, we had to face an embolic occlusion, and actually you can see here by the angiography it's got worse after the Rotarex thrombectomy, possibly due to peripheral embolization. So we decided in that case that we had to do a lysis. Fortunately, the patient did well, and after a lysis and then after the implantation of a Viaban in the proximal side and one supera stent in the distal anastomosis, we had a good flow into the periphery and the resolution of the pain of the patient. So you can appreciate the flow patterns after recanalization. You see sort of a hyperemic flow in the periphery. And the patient came back actually about for a scheduled intervention of the below the knee arteries 6 weeks afterwards. And we also managed to recanalize his posterior tibial artery, and he does well right now, but we do not, of course, have a long-term follow-up in this patient. So probably, I guess, he could have been treated by redo surgery. He could have been treated by reopening of native vessels, but these are also things we do not know nowadays. And the second example is a 78-year-old patient. He also presented with a critical limb-threatening ischemia. He had a crossover bypass which was open, and afterwards he had a failure of his femoral popliteal bypass and also an occlusion of the deep femoral artery. And the first thing we did actually is a reopening of the deep femoral artery, but due to progressed wound healing, we felt that we had to do more. We had to improve blood supply more in this patient. So what we did is a retrograde puncture by ultrasound guidance in this prosthetic bypass, and then a retrograde recanalization And also we combined that with 6-French Rotarex, which this time went well without peripheral embolization, and also implanted a Viaban in the proximal side of the bypass. And the rest, in this case, actually we treated with drug-coated balloon angioplasty, and we managed actually in one single session to have a very good outflow to the foot. He had to undergo, of course, a minor amputation of the forefoot because he had also very progressed wound healing, but when healing went well. Also an interesting case because I guess in this case other options are surely possible, but I think that's also the case, but we need further data and further follow-up, and probably further also in some point of time also prospective data with such complex patients. So that was a presentation from my side, and I would like to thank you for your attention.
Yeah, we would like to thank you, Dr. Korosoglou. It was an excellent idea.